introduction. So I am Dr. Dave Lin from Rehab, so I'm across the street. So if there's any back problems, please let us know. So I'm going to talk to you about the basics of low back pain. So 85 to 90% of people will suffer from back pain, and it is the second most common reason people go to their family doctors. At any one point, 2% of the entire US workforce is disabled by back pain. So it's a very big problem, and it's costing over $60 billion annually. And I've seen some figures up to $100 billion annually in terms of the cost of treating and the time lost from jobs. So we're going to talk about acute back pain, which is not generally a big problem because if it's acute, it'll get better. It's usually a brief episode of pain, and most people will recover within 2 weeks. 90% of low back pain will resolve in 6 to 12 weeks. So the ones that we are more concerned about is the more chronic low back pain. So in order to understand the back, we need to know the basic anatomy. So the reason the low back is the main problem is because it moves. Just remember the thoracic spine, which is above the lumbar area, doesn't move because everything is locked in by the rib cage. So when people talk about back pain, they usually talk about the low back or the neck because that's where the movement occurs. We also need to know there are nerves that come out from the holes. These are called neuroforamen. And there's 5 bones that make up the low back. We want to make sure that there is room for the nerves to come out. We also want to make sure that the disc, which is the shock absorbers, are intact, and those are between the vertebral bodies. So again, they're stacked on top of each other. There's 5 of them, 1, 2, 3, 4, 5, and we want to make sure the nerves are coming out correctly. And that gives you a little look at what a vertebral body or the piece of backbone looks like. Just remember, in between are the discs. People talk about it like a jelly donut. Basically, inside is a gelatinous material, and it's covered by collagen, and that sort of acts as the shock absorber. As you can tell, when force is applied, it tends to spread out a little bit. So we want to make sure that the gelatinous material in the disc is contained. So actually, if you want to be taller, just measure yourself when you first get up in the morning. Because when you first measure yourself in the morning, your height that is, you're about ½ an inch taller because of the fact that all the discs are full of water because you're lying down. As you move around during the day, you get just a tad shorter because the disc loses a little bit of water in height. And there's a lot of disc because the disc for the thoracic spine and also the neck also. In order to understand the mechanics, when you bend forward, you put more pressure on the disc. You see here, when you put more pressure on the disc tends to jut backwards, and that's a concern because the nerves come out of the holes in the back part of the spine. So in a more neutral or extended position, there's less stress or force on the disc. So again, bending forward puts more pressure on the disc, and the disc tends to jut backwards when you put flexion force onto the disc. And also remember, there's a lot of muscles in the back. The primary back muscles run up and down the spine, so they're all in that sort of longitudinal orientation. There's also some superficial muscles like the latissimus that goes more horizontally. So there's back muscles, but you also have to think about muscles that make up the core. So the core muscles not only include the muscles of the back, but they also include muscles in the front, and those are the abdominal muscles. So it's important to strengthen not just the back muscles, but also the muscles that make up the front of the core. So those are your transverse abdominis, your rectus abdominis, and the obliques. So they should be sort of strengthened in unison. I also want you to make sure that everything is connected, so the hips are also very important. The hips connect to the pelvis, and the hamstrings and the other ligaments can control hip motion. For example, if you have tight hamstrings, it will prevent the normal movement of the pelvis, and that can lead to more back pain. So also very important to consider the hip when addressing the low back. And there are also ligaments. Unfortunately, ligaments cannot be strengthened, but they're the connections between the bones. They go from bone to bone, and there's multiple ligaments throughout the low back. If you put a lot of pressure on the ligaments, it could tear, and that could also cause low back pain. So especially if you bend forward, it puts a distraction stress on those ligaments. So what are the common causes of low back pain? So we're going to talk about the main causes, then we'll talk about some therapy options that you can consider. We're going to talk about muscle strain, ligament sprain, herniated discs, disc pain, foraminal stenosis, arthritis, central spinal stenosis, and compression fractures. So those are the most common causes of back pain that most people experience. But the first thing is to make sure there is nothing serious. So most back pain is considered benign. So we always want to make sure there's nothing huge. So we always ask for bowel and bladder problems because that would indicate a nerve issue. That could be a surgical emergency. We want to make sure there's no trauma or night pain. So if there's more pain at night, it could indicate a tumor because there's more blood flow when you're lying down at night to the tumor, which is more hypervascular, and you have more pain from that. We want to make sure there's no history of cancer or people on immunosuppressive medicines like steroids, as that they could cause you to have a decreased immune response and more prone for infection. We want to make sure there's no weight loss, fever, chills, and saddle anesthesia, which means you can't feel the area around your buttocks. We also want to make sure there's no weakness or sensory loss, because that can also indicate a neurological injury. So the first thing to do is to make sure there's nothing huge. And there's a lot of things that can cause back pain. But if you look at this is a very busy slide, but 97% of back pain is mechanical, considered benign. Whereas the other things like infection and tumor, this makes up the rest of the 3%. So we make sure that it's not an emergency before we proceed. So most people will have mechanical low back pain. So the first mechanical low back pain we're going to talk about is muscle strain or ligament strain. And what that means is that the muscle fibers or the ligaments get overstretched or overused. And usually it's a stretch injury. Sometimes it becomes very tight over time and becomes more chronic, what we call a trigger point. And that's a hyper-irritable focal spot that's usually in a tight band in the muscles itself. So what we look for is a referred pain pattern. So let's say the trigger point is up here, but sometimes that pain can refer down to the buttocks. The reason there is a referral pattern is because the injury stimulates the brain. There's a sort of a central stimulation that occurs, but even though the problem is more in the muscle. So we look for these referred pain patterns. So again, this is a chronic issue. What do? Well, the first thing, we medicate. Now, that may not be the best thing to do initially, but that's what we tend to do. Because if there's acute pain, we give Tylenol or anti-inflammatories like ibuprofen or naproxen. There are also fancier ones that we can give, like meloxicam or things that require a prescription. Sometimes we could give muscle relaxants like Flexeril or cyclobenzaprine. We give pain patches. We give tramadol. We give opioids or narcotics. So this is probably okay to do for a few days, maybe a few weeks, but not really something that should be considered a long-term solution. And us physicians have been at fault for over-prescribing these medicines. And obviously this is sometimes causing people to depend on pain medicines. So the best thing is not to rely on pain medicines for a long period of time. And also to understand that these pain medicines do not cure you. They're only to block the pain temporarily.
What's the long period of time?
Well, that's debatable how long the period of time should be, but I would say less than a month. Generally especially with narcotics, it should be just for a week or less, hopefully. So other things we can do besides giving medicines is injections. Okay, so one thing is something called a trigger point injection, where if you could find a knot, you could pierce the skin and needle the knot. there's two ways of doing it. One way is with a hypodermic needle, what they call a trigger point injection. You inject usually lidocaine to break up the knot. Or better yet, you could use something called dry needling, using an acupuncture needle. What makes that different is that the acupuncture needle is not that sharp, doesn't have a hole in it, so it just separates out the muscle instead of stabbing and causing like a hole in the muscle. So the acupuncture needle is much smaller without a hole in it, so it can allow for better separation of the muscle. And there has been studies that show that if you needle the muscle, it may help with the muscle-related pain. But the best thing to do is, because I'm a physiatrist, is physical therapy. So for a muscle injury or ligament injury, the best thing to do is core strengthening exercises, things to help activate those muscles of your abdomen and the back muscles. The best type of physical therapy, and you'll learn that with a physical therapist, is planks. That will also stimulate the muscles of both the back and the abdominal, and you can also use side planks, which can also get the obliques. So best treatment is core strengthening, and there's various workouts, but you want to make sure that you stimulate and strengthen both the front and the back of the lumbar spine. So these are side planks, and you can see that there is some activation of not just the abdominis muscles, but also the obliques. And if you try to hold these positions for a longer period of time to get that sort of strengthening over, you could do more and more as you get stronger. Another way of getting core strength is doing pelvic tilts. And this is a very easy way of strengthening the abdominal muscles and also stretching out the hamstrings and contracting the hamstrings. Basically, you lie on your back and you push your buttocks and that little arch of your lumbar spine downwards. And you contract that for a period of time, and that would also strengthen your core muscles. So the best way, really, for treatment for muscle strain is physical therapy with a focus on core. Another very common thing that we see is herniated discs or disc-related pain. The disc, again, is actually between the bones, and as we discussed, that putting pressure on it could herniate the disc or it could jut out backwards. The concern is that if it juts out backwards, it could hit the nerve. If it hits the nerve, then it could go down your legs. Now you have back pain, and you can also have leg pain. And you can see the nerves start from the back, and they go down the legs. So if you have that shooting pain down your legs, we call it sciatica. But the reason that you have the pain usually is not from the sciatic nerve. You usually have it from the lumbar nerve roots before the sciatic nerve proper. So what we do is we make sure there is a herniated disc. The best way to see it would be an MRI. On an MRI, this is a side view, we look for the disc jutting out. Then we look at it from the top. And you can see on this view, there's a piece of disc that is jutted out, and that would hit the nerve, and then you would have the pain down your legs. So the MRI is very powerful. You cannot see this on an X-ray. So a lot of patients tell me they see, oh, I saw a herniated disc on my X-ray. But these are soft tissues that do not show well on a routine X-ray. You need an MRI to see this. The MRI can also look for tears, and the tears is a little different. It's not really jutting out, but we see a white spot or a signal on usually the periphery of the disc, and this is the tear here. So in this case, it would just be back pain without the pain down the legs, because usually the nerve is not irritated if it's just a tear, but if it's herniated and hitting a nerve, you have the pain down your legs. So by how it goes down your legs, we can sort of guess which nerve root is involved. So you can see if it's the sort of the top part of the low back, like let's say the L3, it tends to run into the thigh. But if it's further down, the S1 nerve root, it goes all the way down to your foot. So based on how it shoots down your legs, it could give us an idea of which nerve root is involved. So we look for that shooting pain, or what we call radicular pain. So what do we do? Well, we could do medicines. We could even use oral cortisone for a period of time to help decrease the inflammation. But the best way to treat this is with extension-based exercises. What we do know is that if you go forward, you put more pressure on the disc. So what we want to do is do the opposite. We want to go backwards. And we want to also stretch the hamstrings, because if the hamstrings are too tight, it can also put more pressure on the discs. We also want to strengthen the core, but we want to focus on that extension therapy. If it doesn't get better, we can talk about steroid injections or manual traction. So the best thing to do is understand that flexion will make the pain worse. So we want to go backwards. So these are different poses that you could do to help go, you try to suck the disc back in by doing these extension-based protocols. The most famous person is called the McKenzie approach, which is based on these extension-based therapy to help suck the disc back in. And as you get better, this may not show it very well, but you centralize the pain. So initially, when you start doing the physical therapy, it's going down your legs, but as you try to suck the disc back in, the pain becomes more focal and eventually just ends up in your low back. So that's the premise of the extension-based therapy, is to try to centralize the pain by bringing the radicular pain more focally into the low back. Other things you can do is manual traction. The physical therapist can do it with a belt to distract the bones, to give you a little bit more space, or there are actually traction machines that are available to help open up the space for where the nerve comes out. So these are things that can be done in physical therapy. And there are also braces that are sold. These braces are called traction braces, where you pump full of air, and it pulls the body up and down to distract the bones. So based on their literature, of course, these are biased from the company, but there's a little bit more disc space when you have the brace on. So some people find it very helpful because you can wear this throughout the day, and it can provide you relief as you're walking around. So there are these traction braces that are available. And remember again that those hamstrings, because if the hamstrings are tight, it prevents that full motion of the low back. Again, that hamstring is attached to the pelvis where you sit, called the sit bone. So if it's tight, it prevents that forward motion of the pelvis. And then when you bend forward, you just put more pressure on your discs and your low back. So part of the focus should also be on making sure that the hamstrings are stretched so they can reduce the pressure over the low back if you do need to bend forward. And these are some basic hamstring stretches. And just remember, you should not do dynamic stretches. These stretches should be sort of static and held for 8 to 10 seconds. You may want to consider using some heat or ultrasound to help limber up the muscles before you try to stretch them out. So these are various ways of sort of stretching the hamstrings. If all else fails and the pain is very severe, there are injections that we can give. The most common injection is called the epidural. An epidural is just a basic injection of cortisone around an inflamed nerve root. It's considered pretty safe, but there's always a small risk of bleeding and infection and a slight risk of paralysis. So, I would say try to do the physical therapy and conventional treatments first before trying these type of more advanced interventions. There is a small risk, but they're generally very effective if you know the true cause of the pain. But I think these injections are overused because a lot of times we don't know the true cause, and then we do these procedures and it doesn't really help. So we talked about muscle strain, we talked about discs. There's another thing called foraminal stenosis, and this is a type of arthritis. It's basically the blockage of the nerve where the hole, it's blockage of the hole where the nerve comes out. And again, this is not usually from a disc, in this case, it's from arthritis. Near the hole where the nerve comes out, called the neuroforamen, is the facet joints, or these joints that form the back of your lumbar spine. Over time, they could get arthritic. And what happens when you have arthritis is the bones get bigger. When they get bigger, they start invading the space where the nerves are. So we can see this on MRI. Looking at a side view of your low back, we want to make sure we can see the nerve coming out and some fat or just space around the nerve. However, if you have arthritis, that space is blocked. You can see the one above it and the one below it, you can see the nerve, but then if there's arthritis, then it blocks the nerve, then you can have the pain down your legs. Just remember, if this is arthritis, you probably had it for a long time. So it has to be very bad before you start getting these symptoms, because your body adapts to it. So sometimes the blockage is almost complete before you really even notice that you have this type of pain. So what do we do in terms of physical therapy? Well, we do know that when you go backwards, what happens to the hole where the nerve comes out? It becomes a little smaller. So going backwards or extension makes the hole where the nerve comes out smaller, whereas if you go forward or flexion, it becomes bigger. So in terms of the type of therapy that we would prescribe, then we would want to go into flexion. We want to bend forward to help open up the space where that nerve comes out. So in these cases, we would do a flexion-based exercise program. So these are some basic flexion poses that people do, and as you get more advanced, you get more and more flexed. So this is to help open up the space where that nerve comes out. So you can start even with lying down, then you can progress to seated, and then more of a standing position. So these are flexion-based therapy. Again, if the pain is severe and going down your legs, then we could give you a shot of cortisone. That's called an epidural, sometimes also known as selective nerve root block. But that's basically injecting cortisone right near where the nerve comes out. But remember, when you're getting these injections, it doesn't open up the space. It's just calming down the inflammation. So it's not solving the real issue. The space is still tight. So it may provide you with relief, but it doesn't really solve the issue completely. So hopefully the injections are done so people can do more physical therapy, and then hopefully over time that space will be a little bit bigger and the pain will resolve. Along with that is something called facet arthritis, and that means there's pain in the back part of the spine. When we look at the spine, most of the weight is in the front. About 80% of the weight is in the front. But in the back, there's two struts called the facets. And they take weight too, about 20% of the weight. Over time, these facets, and they're along the spine, they get inflamed or bigger, and they can also cause pain, the facets itself. So on MRI, what we look for bigger joints. So this is looking at the axial view and looking at what the facets look like, and if they're arthritic, they get bigger. They get bigger, and there's white stuff in the middle. It's a joint, so white stuff means there's inflammation. So sometimes it could be inflamed and arthritic. So one thing we could do is to try to block that area. Blocking that area requires an injection, usually with cortisone or lidocaine. We could block the nerve that goes to the facets, or that's called the medial branch, or we could inject the facets itself. It's very difficult, more difficult, to inject the actual joint, so most people will block the nerve that innervates the facets. So similar to the foraminal stenosis, we want to prevent extension. So in this case, you want to unload the facets. So if you look at this little picture here, going backwards puts more pressure on the facets. Going forward unloads the facets. So again, you want to go forward. So in this type of problem, the physical therapy would be based on flexion. You want to open up the space, and you want to distract the fragment, the facets. And if all else fails, you can consider either an injection directly into the joint or blocking the actual nerve that goes to the joint. So those are other options. If blocking the nerve helps, if you want more long-term relief, we could give you something called radiofrequency ablation. We could burn the nerve, and that would help for a longer period of time, up to 9 to 12 months. The problem with this is over time, the nerves will regrow back, and so you may need the procedure again. Sometimes when it regrows back, it doesn't go exactly where it's supposed to go. So the procedures can be a little bit more difficult if you have 2 or 3 or 4 procedures down the road. But people do find that this helps if the facet joints are very painful. And there's also something called central spinal stenosis, and that basically is that there's no space in the central spinal canal. What that means is that usually we see a lot of nerves right in the center of the spine. The spinal cord is ended, and in the lumbar spine, it's just a bunch of nerves called the cauda equina, and they eventually come out and form the sciatic nerve. In central stenosis, arthritis and maybe the disc, they invade the space and they hit a lot of nerves, not just one, but a whole lot of them. So this is very difficult to treat because it's a structural issue and it's very hard to open up that space. So on a side view, you can see that this area right here, there's no space for the nerves, because you see there's a narrowing of the spinal canal. But the best way to see this will be to look at it from the top. So this is a normal level. You can see little dots. These dots are the spinal canal and the nerves. The nerves are the dots. Whereas if you have stenosis, the arthritis and the disc invades the space and there's no space. You can see there's a lot of white stuff, that's spinal fluid, whereas there's no white stuff over here. So this is arthritic, so you could be very, very bad before you notice anything because your body will adapt to it. If this happened very quickly, you may be paralyzed. But if this happened over a decade, then your body sort of adapts and it may not be so bad until the very end. So this is called central spinal stenosis. And what we do know is that people tend to like to go forward in spinal stenosis because it opens up the space. So a lot of people like to use a cart, or like the shopping cart example is very popular. And most people have more pain when they walk because they could go into the extension, and that would cause more pain with regards to the nerve. So you can see that when you bend forward, that space opens up in the spinal canal, but going backwards, that space gets a little decreased. So in this case, in spinal stenosis, we would advocate for a more flexion-based program. So these are also other ways of doing a flexion-based program, starting from sitting and then using the seat. So that's the flexion-based program. Another thing that we see is compression fractures, especially in the older population. People lose their bone density or their bone stock, and the spine is not as strong as before, the bone that is. And what happens is that the bones sort of crumble a little bit, and that causes a fracture. This is called a compression fracture. It looks like this on X-ray. Basically, usually the compression is in the front of the spine, what we call a wedge-shaped deformity. So with this type of pain, generally bending forward would cause more problems because you're putting more pressure on the fracture. So what we want to do is we want to go backwards. Backwards will help with compression fractures because it will help unload the front of the spine. The way to go backwards is you could usually do exercise, or there are braces. These braces are quite effective. This particular brace is called a Spinal Med 4, and it puts your spine into a little bit of extension. So it unloads the front of the low back. So if you wear one of these things for, not forever, but for 2 or 3 months, it will allow time for the bones to heal, and hopefully the pain will regress over time. If you don't get better, or if the pain is very severe, there's something called kyphoplasty, where they inject cement into the spine to prop it back up. This is obviously a surgical procedure, and somewhat, there's risk with that. But if the pain is unbearable, that's another thing to consider. But obviously, the best thing to do is still physical therapy, bracing, and a little time before jumping into more interventional procedures. So what we talked about is something called directional preference. So we'll just, in summary, if it's a muscle, we should do core work, strengthen the core. If it's a disc problem, then we should go backwards, or extension-based therapy, because that will unload the discs. If it's a stenosis where the nerve comes out, called foraminal stenosis, bending forward would help, or flexion therapy would help, because it will open up the space. If it's facet arthritis, it's also bending forward. If it's spinal stenosis centrally, it's also bending forward. Whereas if it's a compression fracture, going backwards would help. So knowing what type of problem you have, you can prescribe a type of directional preference physical therapy that would aid in terms of the patient's pain and recovery. But it's not that simple, because nobody is just purely one thing or another. So unfortunately, most back pain is non-specific. And actually, I hate to say this, but 90% of patients who come to primary care for back pain, they have non-specific back pain. Serious conditions, again, it's only like 1 to 2%. And sometimes it's not really possible to give you a definitive source of pain. And that is the problem with low back pain. But what we do know is that physical therapy, even non-specific physical therapy, will make you better. Or at least the studies have shown that people do get better with conservative care. We also have to consider other things besides the biological factors. There's other psychological factors and maybe social factors that may also contribute to the low back pain. Especially in the workforce patients, there's workers' comp, and there's also issues with people getting paid and things like that. So those things also play in terms of why people have back pain for a prolonged period of time. Other things to consider is modalities. You could use heat or cold, and basically whatever makes you feel better, we could do. Heat improves the blood flow, it makes things looser. Cold decreases inflammation and blunts the nerves. Some people use both. You could use heat or cold. So generally it's ice if it's an acute injury. Like if you sprain your ankle, it's ice. But if it's more chronic, then you could use heat or ice. And sometimes if you want deep heat, you could use ultrasound. Ultrasound will help, but not for a long period of time, but usually for 5 minutes or 10 minutes, that may help limber up the muscles. You could use TENS, which is using electrical stimulation. How that works is that it blocks the nerves. The painful nerves are very slow conducting. So if you keep on stimulating the non-painful nerves, which are fast acting, it prevents the painful stimulus from going through. So you have to wear this all the time for it to work. But there are units that are marketed that you can wear all the time. So this is a cheap way of controlling pain if it's not that severe. So this is called TENS, or transcutaneous electrical nerve stimulation. You could try acupuncture. Acupuncture, if you believe the issue with the qi and moving the qi around to help with healing, that may be something you can consider. What is interesting about acupuncture is that we do know it does work, but so does sham acupuncture. So they've done very large studies in Germany, over 10,000 patients. And they've clearly saw that back pain gets improved with acupuncture. But they did fake acupuncture, randomly stick needles in you, and then do real Verum or true acupuncture. Both groups did equally well. So it works. We don't know the mechanism. Maybe just putting needles in you will help, but it does. It has been proven that it does work. These are very large trials. And you can consider other things like Tai Chi, yoga, prolotherapy, which is injecting sugar water, cupping or guasa, which is basically using spoons or coin to create an inflammatory response to the skin. There's a lot of talk about stem cell therapy. If it's off in the mind, you could use cognitive behavioral therapy. There's cold lasers, massage therapy. So there's a lot of things that people do for back pain. Yes, ma'am?
Would Pilates?
Pilates will be fine too, but unfortunately, none of this is really proven. But if it works for you, then I would do it. Not proven, and then hence not paid for by insurance, unfortunately. So that begs the question, are we over-treating low back pain? This is a big problem, but if you look at the Medicare data, this is from 2000 to 2014. That's a 14-year span. The bottom is the number of epidural injections, and the top is the number of other interventional procedures. So in the course of 14 years, we almost have a threefold increase in procedures for treatment of low back pain. So my concern is that even though I'm a physician and we like to do things to you, I think we're doing too much. And maybe the quick fix with just an interventional procedure is not the right way to go. I do think they're effective in certain situations, but I think they're being overly used. So we are definitely in 14 years doing over 5 million procedures per year. So that's quite a bit. The other thing you need to consider is that we will always find something wrong with you. Actually, not one thing. We'll probably find 10 things wrong with you. So be careful when you get that MRI, okay? Because we will see disc degeneration in people with no pain. At the age of 20, 37% will have some kind of disc degeneration. A 20-year-old asymptomatic person will find something wrong with you even at 20 years old. When you're 80 years old, 96% will have some kind of finding with their discs. We know that disc bulges are in 30% of 20-year-olds and 84% of 80-year-old patients. So the bottom line is that when you get these MRIs, because people get MRIs all the time, we must make sure that the pain that you have correlates with the MRI picture, because most of the time it will not. And that is a big dilemma for us on how to treat that. Because we will treat you, but I'm not sure if we're treating the right thing, because we'll find a lot of collateral injuries when we get these MRIs. So what I tell my patients is that you should do a core exercise program, just for general health. And the American Academy of Orthopedic Surgeons, and this is online, it's orthoinfo.aaos.org, it's right here. They have physical therapy exercises for people, and it tells you step by step on how to strengthen your core. So these 11 exercises I think are very beneficial to help strengthen the core and help with your pain.
Could you repeat? You can't read it from here.
Oh, I'm sorry, it's so small, I'm sorry. It's orthoinfo, O-R-T-H-O, info.aaos.org. And they will have exercises not just for the spine, but for other parts of the body also. It's an excellent website, so you can check it out. Sure, it's orthoinfo, O-R-T-H-O, info, I-N-F-O, dot AAOS, that's American Academy of Orthopedic Surgeons, .org. .org. It's orthoinfo.aaos.org. So these are the 11 exercises that they have determined to be very helpful for that, for back pain. But the most important thing is prevention. So you want to make sure that you stand with good posture. You want to assess that, you want to try to stand straight. You can use a wall to help align yourself so you know what it feels like to stand straight. And then you just want to be smart. If you want the computers, you want proper ergonomics. And you don't want to put too much pressure on your discs, so you want to make sure that you do things properly by not overstraining your low back. And the most important thing is when you lift things. When you lift things, find a buddy. Don't try to do it yourself. If you need to lift something, bring it closer to your body so it doesn't put so much force on your low back. So use your legs. Don't just rely on your back. Try to use your legs, squat down, grab the object, put it closer to your body. But the best thing is to get help. And then you want to make sure when you're doing your house chores, don't overly bend your back. Try to use a way that you're not stressing the back in your daily life, because that is the best way to, if you don't have it to begin with, that's the best treatment, is to prevent it from happening. And then you also have to remember general health is probably the most important thing. You want to make sure that you're doing aerobic activities. You want to do that smart by doing low impact, elliptical or walking, bicycling, but nothing that's jarring or high impact. We think that when you exercise, it releases endorphins and enkephalins that make you feel better. You can use a pool, because that will help release some of the stress by the buoyant effect of the water. You want to make sure you have good nutrition, maintain a healthy weight, and make sure you sleep well. So all those things will play a factor in terms of pain. And then a little bit about what I am. I'm a physiatrist, and most people don't know what physiatry is. We are rehab doctors, and we have a specialty training in function and mobility. We deal with nerves, muscle, and bones, and we figure out how these things affect your movement and function in life. We want to restore maximum function, and we also can diagnose and treat pain, and we do this non-surgically. So we really use therapy and other modalities to try to get the pain under control. Thank you so much.